next session, it's a proud privilege to introduce our chairpersons for the next session, Dr. Anjila Aneja. She's with us. She is the Director and Head Minimal Access Surgery, Fortis Memorial Research Institute, Gurgaon, and Director of Obs and Gynae at Fortis La Femme. She is President, Delhi Gynae Forum South, and Chairperson, AOGD Endometriosis Subcommittee 2021-23. She's also the Treasurer, RCOG NZ 2021, and her areas of interest are okay. Our next chairperson is Dr. Jyoti Bhaskar. She is the President, East Delhi Gynae Forum, Co-Chairperson, QI Committee of AOGD, Secretary, IMS Delhi Chapter, and Clinical Director, Apollo Cradle, Indirapuram. And last but not the least, Dr. Shashi Kabra. She is ND faculty and recipient of Wonder Foxy Award 2019. She is a senior specialist OBGYN with DDU Hospital and also chairperson multidisciplinary committee AOGD 2022. Welcome, madam. I would request Dr. Angela to kindly introduce our very dynamic speaker for the next session. Thank you.
Hi, good afternoon, everyone. After such a wonderful talk by Dr. Sadhna, we are going to have another talk by another wonderful speaker, Dr. Rekha Bharti. Dr. Rekha Bharti is a professor, Vardhaman Mahavir Medical College and Safdarjung Hospital. She is an editor, AOGD 2021-2022. She's a member of AOGD Endometriosis Committee and a member of Foxy HIV Committee, and she has many publications and many awards. And I'm proud to say that she was a postgraduate student when we were a senior resident at Harding, and she has done such a wonderful job. And we are so proud of you, Rekha. And, many times we think, why should we listen to cesareans and what are the new techniques into it, But you must understand, there's so many things which have changed now. And we have to do away with few things and we have to follow the new practices. So Rekha is going to elaborate on the newer techniques in cesarean section. And let's see and try to change ourselves in our day-to-day practice. Because, cesarean is not something which is going to go away. It is going to stay with us forever. Over to you, Rekha.
Thank you, ma'am. And it is really a very proud moment for me to present this, topic in front of three of my senior residents under whom I learned doing cesarean section. So Dr. Angela, Dr. Meenakshi, Dr. Jyoti, all three were there in Harding when I was doing my post-graduation. And I think I learned the technique from all three of you. So today,
yes,
ma'am, I still remember. Breathe cesarean without telling anyone. I was a first year PG. I can never forget that. So I know, and it is really a very proud moment for me to have three of my senior residents here on this forum where I am going to make my presentation. And this is, not really all the new techniques. So what basically I'm going to present today is what are the techniques which we are using. So all of us, we are comfortable with using certain techniques. So I'm just going to elaborate on that, whether we are doing something right or wrong, or whether we think this method is right, that is wrong, or both are, similar as far as the complications and the post-operative, the problem of the patients are concerned. And secondly, very important thing that I'm going to highlight is, which even Dr. Sadhna just talked about, eras. So now as she ERAS Society for pre-operative and operative period of the women who are undergoing cesarean section. So I'll just share my slides and I'll try to be very, very brief on the things because I know we are running short of time. So I'm just starting with perioperative period because it is very important to maintain normal physiology in the perioperative period to have its effect on the post-operative period. And there are enhanced recovery after surgery protocols even for cesarean section, all three phases. It comes as part 1, 2 and 3. And these protocols starts 30 to 60 minutes before the skin incision, and they are up till the discharge from the patient. So I'm just going to talk about two parts, pre-operative and para-operative. So basically, first very important thing is timing of taking consent, which we all know. Dr. Sharda Jain talked about, all these litigations and things happening. And Dr. Sadhna also just highlighted how we can get into trouble if we are not careful about taking consents. Then second thing is fasting before cesarean section. We all have learned that the pregnant women, they have delayed gastric emptying. So, it was generally a practice to keep the woman nil orally after midnight or maybe after 10 p.m. But nowadays, as for other surgeries, short fasting periods are recommended. So women are advised to take light meals up to 6 hours before surgery, and they can take clear fluids up to 2 hours. And there is this, non-diabetic patient can be given carbohydrate drink, but this for the cesarean is not yet, it is still a very weak recommendation.
Dr. Rekha, your slides are not moving.
Not moving?
No.
Okay, so is it moving now?
No, you will have to
I think I'll just put it on slide.
Yeah.
Slideshare.
I'll stop this.
Yeah, share again and then make it on
I'll put it on slideshow and then share it.
Yeah.
I thought my net was not working.
अरेस्ट हो गया, लेबर अरेस्ट हो गया, सिजरिंग करो.
Yeah. Yes, I think now, are they moving now?
No, it's not showing your light at all. Yeah, now it's there.
आ गया.
हाँ, it's there.
Yeah, up to my slide show.
Yeah, it's there.
Let's go from the beginning.
So, this is just what I talked about, and then we were that in the non-diabetic patient, carbohydrate drinks is advised 2 hours before surgery. Approximately 50 grams of carbohydrates are given, but still, we do not have very good evidence-based studies on this in pregnancy, although it does exist for other surgeries. Then pre-operative medications in the form of antacids and histamine H2 receptor antagonist is also a very strong recommendation, which prevents aspiration pneumonitis in patients. Then we all know about giving prophylactic antibiotic, and we have seen the change that has come. Previously, we were told to give antibiotic at the time of clamping of the cord, but then latest evidence has shown that if you give it pre-operatively 30 to 60 minutes, within 30 to 60 minutes of cesarean, then it has better control of infectious morbidity than if you give it at the time of cord clamping. Another recent thing, not very recent now, these recommendations have been there now for quite a long time, even by ACOG also, that you should add azithromycin to patients who are being done for cesarean during labor. So there, azithromycin, giving azithromycin can be at the time of cord clamping if you want to avoid its effects on the baby. Then surgical site preparation, we all have been doing it for a very long time, and we all know that even antimicrobial soap baths are recommended before planned surgeries. And regarding chlorhexidine alcohol scrub and povidone iodine solutions, both have been shown to have good results, but for the inherent complications which can be associated with povidone iodine, people are now recommended chlorhexidine alcohol scrub. For routine surgeries, it has already been seen that chlorhexidine scrubs are better than povidone iodine, but we yet to have document their benefits in cesarean delivery, but still this comes with a strong recommendation. As far as use of medicated drapes are concerned, they are of no benefit, but they do add on to the cost of the surgery. Then vaginal preparation, we know that WHO also recommends that all vaginal preparations to be done with povidone iodine. But in India, there is still, a fear. Our pediatricians are not very comfortable for us using povidone iodine. One is the risk of allergic reaction. Second, because it is hyperemic vagina, the absorption of iodine can be there, which can lead to neonatal hypothyroidism, especially in countries where women are actually deficient in iodine. And it could also cause false positive neonatal screening test for thyroid. So chlorhexidine solution alone or in combination with cetramide can be used in such settings. Then intraoperatively, we all know regional anesthesia is preferred. Now, there is a recent study that has come which has seen that even doing cesarean under general anesthesia also will not cause increased incidence of aspiration pneumonitis or mortality. But then this study lagged the power of the study was less, because as such, whether it is with regional or under general anesthesia, we are having less of anesthesia related morbidity and mortality. But the patients who have surgery done under general anesthesia, they have more of post-operative sedation. So that is why regional anesthesia is better. And patient monitoring to prevent hypothermia is very, very important. Nowadays, we know that patients who have hypothermia during surgery, and 50 to 80% of patients who are being done under spinal anesthesia will have hypothermia. And this can cause post-operative infectious morbidity, and also, per-operative risk of more complications like increased bleeding. And if it is more, it can even interfere with coagulation of the patient also. So forced air warming, warm IV fluids, and increasing the temperature of operation room is recommended. Then as far as pre-operative bladder catheterization is concerned, we just had a brief discussion on this, and it is well documented that there's no difference in the bladder injury when the cesarean is done with or without drainage of the bladder. Now, coming to the cesarean technique, this also we were just discussing the technique which was introduced by Rajurkar. When it is combined with phalansteal incision, it is called phalansteal technique. Then Joel-Cohen method and Misgav-Ledet technique, or modified Misgav-Ledet technique, which has actually combined the previous techniques of cesarean section. Then we know previously also we did have people who were recommending extraperitoneal approach. So just briefly talking about it, these techniques, they do differ slightly in the type of incision or subcutaneous tissue opening and opening of the uterine incision, placental removal, uterine closure. But then what is recommended, we'll just talk about it. Then extraperitoneal approach, nowadays people are not very familiar with it, though there are few surgeons who are very fond of this approach. This was primarily used in pre-antibiotic era. It needs a detailed knowledge of relationship between the facial planes and bladder. It avoids exposure of the peritoneal cavity, so contamination of the peritoneal cavity can be avoided, and there is decreased incidence of nausea and vomiting in the post-operative period, and even voiding disturbances are less when extraperitoneal approach is done. Now, coming to the skin incisions, we all know transverse incision are better for the cosmetic purpose, and in the transverse incision, we have either phalansteal incision or we have Joel-Cohen incision, which is generally being given in these days most of the time. So it is basically the Joel-Cohen incision. As you can see, it is a straight incision which is 3 centimeters below a line which joins the anterior superior iliac spine. And the phalansteal incision, it is around 2 to 3 centimeters above the pubic symphysis. Now, as far as Joel-Cohen incision is concerned, because we are doing the dissection of the subcutaneous tissue and the fascia by blunt dissection, it decreases the post-operative febrile morbidity. There is less need of post-operative analgesia. Operating time is also reduced. There is reduce in the blood loss, and total dose of analgesia required is also reduced, and there is decrease in the hospital stay. Now, we know that there are many people who actually prefer using scalpel, and there are surgeons who prefer to open the skin onward incision with electrosurgery. So if we see the both techniques, neither scalpel nor electrosurgery has clinically significant benefit over the other for skin incision. So either of these techniques can be used according to the preference of the surgeon. And there are people who would like to use the mixture of technique. They would like to open the skin with the scalpel, and further dissection they will do with the electrocautery. Then we, from beginning only, we were in the habit of changing our scalpel blade after opening the abdomen, just to decrease the contamination of the skin contaminants, taking the skin contaminants into the abdomen. But it is seen that this does not reduce the rate of wound infection. So there is no point, in changing the scalpel. You can do whole surgery with one scalpel. Then subcutaneous tissue layers, we know there are people who prefer blunt dissection or who prefer dissection with the sharp. Blunt dissection with fingers is associated with shorter operative times and less chances of injury to the vessel and less post-operative pain. So in the Joel-Cohen incision, subcutaneous layer is opened by sharp only in the midline, then laterally it is extended by the fingers. A small transverse incision, and then you extend it laterally, and Basically, this avoid your cutting off the lateral vessels and all. And then there is thing is that fascia, whether you do the fascia laterally you extend or you pull it cephalocaudal direction, there is no difference in the post-operative pain scores with sharp or the blunt dissection. But the only thing is the blood bleeding at the time of the incision is definitely less with Joel Cohen incision. Then rectus muscle layer, and it is separated bluntly by pulling. This is done in all the techniques. Maillard technique should be avoided as far as possible, because if you keep the muscles intact, it preserves the strength of the abdominal wall in the early post-operative period. So opening the peritoneum, blunt opening or sharp opening of the peritoneum, both techniques, in both techniques, there's no significant difference in the maternal death, infectious morbidity, and requirement for further operative procedure or transfusion of blood more than 1 point. And so both, whichever the surgeon is comfortable with, this technique can be followed. And how long the incision, abdominal incision should be, we all know 15 centimeter. I still remember Dr. Meenakshi teaching us, it should not happen that you deliver the baby from the uterus and it gets stuck in the abdominal wall. So this is important. Then whether to create bladder flap or not. So there has been meta-analysis of many trials in this. And there is no increase in the short-term adverse outcome, whether you create flap or not. And but by not creating the flap, definitely you reduce the risk of bladder hematomas. The urinary symptom score at 6 to 8 weeks was similar in both patients who had in which the bladder flap was made or the surgery was done without making the bladder flap, that is pushing the bladder down. So but within 6 to 8 weeks time, the symptoms, urinary symptoms, were more in women who had bladder flap creation as contrast to those who did not have making of bladder flap. Then uterine incisions, we know blunt versus sharp. So there are surgeons who are fond of opening the uterus by blunt expansion after giving initial incision. So in all the techniques, generally it is a sharp incision, but the incision is extended by a blunt dissection. And then whether you open it by sharp incision or you open it by blunt finger incision, but with blunt expansion of the incision, you lower the unintended extension. So extensions are lower. Drop in the hemoglobin is lower with the blunt extension, and shortening, there is short operative time by 2 minutes. So now a very important thing is that we all have been opening the abdomen by extending the incision laterally, but in the new era's guidelines, it is recommended, and there are studies on this, that lateral extension of the incision is less if you are taking the incision in the cephalocaudal direction rather than extending the incision laterally. So extensions are less, hemoglobin drop is less, there is less injury to the uterine vessels, blood loss is also less. And there is less need for taking additional stitches if you are opening it in the cephalocaudal direction. Then J and T, we all know, should be avoided. They are weak incisions. Then fetal extraction, it is very important that there is a direct association between prolonged uterine incision to delivery time and low ABGAR score, and even the fetal blood gas pH values are also lower, and it is regardless of the anesthesia used. It is not that if the general anesthesia, we should be very fast in taking out the baby, but even in the spinal anesthesia, if there is prolonged time between the uterine incision and delivery of the baby, then there can be lower pH value in the cord blood. Then fetal extraction, we all should know that pressure should not come onto the lower incision, and you have to be very careful so that you do not extend the incision downward. So this we all have been practicing. I think we all are aware of it. Now the placental extraction, spontaneous with gentle cord traction, is what is recommended. Now, there are few people who prefer to change gloves because they feel now from the contaminated cavity, you are going into a cleaner cavity after placental extraction, but this was not associated with decrease in the infectious morbidity. So changing of glove after placental extraction is not recommended. Then manual placental extraction is associated with higher post-operative endometritis, greater blood loss, and lower post-operative hematocrit and longer hospital stay. So it is, not preferred that you do MRP in all the patients. Then cleaning the uterus. So there are few surgeons who prefer cleaning the uterine cavity with gauze, but there is insufficient evidence regarding this. And then second thing is exteriorizing the uterus. This even I know before, I read this meta-analysis, I used to feel, and that is what, we all used to feel, that if you take out the uterus, the patient has more tendency to have nausea and vomiting. But this has not been found in the trials. So whatever way you are comfortable, if you want to exteriorize the uterus and suture it, or you want to suture it inside the abdominal cavity, it is the preference of the surgeon. Then uterine closure. Now we know that all studies are in favor of 2-layer closure. The important thing here, which I want to highlight, is that initially we were told to leave the decidua, but nowadays there are studies that which say that you should take full thickness of the uterine wall. So first layer has to take the edges of the decidua also. And as far as using blunt needles is concerned, it is important that so that you can avoid the needle stick injury. But then it is the surgeons generally do not prefer, for the obvious reason that you have to use slightly more force, but they are definitely, there is decreased chances of glove perforation. Then locking sutures should not be used. It should be continuous suture, otherwise you are going to cause the ischemia of that part. So it is seen that if you incorporate the myometrium and decidual edge, frequency of the wedge type healing defect on ultrasound 6 weeks postpartum is significantly lower. So this is, a thing which we all can modify if we are not taking decidua, or we are, scared to take decidua, that it will weaken the your stitch line, but this is not the case. Then choice of suture material, we all know, we all have shifted now to polyglectin 910. So this is what is being recommended also, but they say you can even use chromic catgut. There is no statistically significant difference in the maternal outcome. Unnecessary procedures are cervical dilatation and uterine irrigation. They may cause more harm than do good to the patient. Then closure of the peritoneum. It is basically has been shown in many meta-analysis that by closing the peritoneum, you increase the operative time by 6 minutes, but there is no difference in the adhesion formation. Rather, leaving us more of the suture may lead to more of the adhesion formation. Reapproximation of the rectus muscle can cause post-operative pain, and but there are no randomized trials that have evaluated closure versus non-closure. But they say that the stitches may give way in the post-operative period and may cause more post-operative pain to the patient. As far as wound drains are concerned, it is better not to put drains routinely. So all the infectious morbidity is not reduced. Rather, they have seen increase in risk of wound disruption if you are leaving the drains. This is very important, and I still remember when I was a PG and Dr. Angela was very particular that you suture the subcutaneous tissue if it is more than 2 centimeters, and this recommendation is being continued. And then another thing, previously the surgeons, few surgeons, they were in habit of leaving the subcutaneous tissue drains if the subcutaneous tissue was more than 4 centimeters, but it is not associated with any advantage. So as far as skin closure is concerned, interrupted and continuous subcuticular sutures. So everybody prefers subcuticular sutures. As far as giving the staples is concerned, actually the studies which are there with the staple, they showed, more of the wound disruption, but then their staples were removed within 4 days of the cesarean section. So this was, a trial which analyzed the short-term and long-term complication. And this was seen that all this data which has come has been shown here also, that there is no difference between blunt or sharp entry of the abdomen, exteriorization of the uterus, or these were the factors, which were analyzed: single layer closure versus double layer closure, or chromic catgut versus vicryl, and closure versus non-closure of the endometrium. And after 3 years follow-up, they did not observe much. These all differences, they were not statistically significant if you see that 95% confidence interval. So there was basically no difference in the infertility, ectopic pregnancy, maternal death rate, or uterine rupture. Even with, if you are doing with chromic or vicryl, the rupture rates are same. And closure of or non-closure of the peritoneum was not associated with infertility. Now, these are the ERAS procedures, pre-operatively. I have already taken many of them. So this is just a summary of the recommendation, newer recommendation by the ERAS societies which are there. So pre-admission, which I was saying, and we were talking before starting this session today, that how litigation can affect the surgeon. So here, if you see what all you have to explain to the patient. So these are the 7 points which are given there. And if you go into the depth of it, the patient should understand that what is the reason or indication for doing cesarean delivery, what will be the location of the incision. This should be told to the patient beforehand, and the closure technique which we are going to use and why we are going to use that closure technique, preventive efforts used to minimize post-operative infections, like what preparation of the skin or antibiotics we will be giving her, and then individualized post-operative risk assessment of thromboembolism, and we should be using the mechanical methods in all the patient, and the pharmacological methods can be used in patients who are at high risk of developing venous thromboembolism. So gastrointestinal and what the patient expects in the post-operative period, and what the mother and baby can have in the post-operative period. So this all should be told to the patient. So this is, very important part of taking consent. Then there are, 4 focused pathways in which there are 6 recommendations. 3 are positive, 2 are negative, and 1 is, plus minus type. So giving antacids is positive recommendation. Giving preoperative sedation is negative recommendation. It should not be given. And oral and mechanical bowel preparations should not be used in patients who are undergoing cesarean delivery. Then women should be encouraged to drink clear fluids up to 2 hours before surgery, light meals up to 6 hours before surgery. Carbohydrate supplementation for cesarean, it is still a low level of evidence and weak recommendation. So there are studies still going on this parameter. Then intraoperatively, the administration of antibiotics 60 minutes before the delivery, and it has to be first generation cephalosporin. And in women who have had rupture of membrane or who are having cesarean in labor, addition of azithromycin is a strong recommendation. Chlorhexidine alcohol preferred over iodine. It is low evidence because for cesarean there is not much evidence, but still it is a strong recommendation because from other surgery these are all, anyway high level of recommendation have come for the other surgery. Vaginal preparation with povidone iodine should be considered to reduce the post-cesarean infectious morbidity. It is a moderate level evidence and it has a weak recommendation. But we also had, one study done in our institute. We did it with the chlorhexidine cetrimide solution, and we saw that it was more helpful in reducing infectious morbidity in women who are having in-labor cesarean rather than women who are having cesarean during labor. Intraoperative care of cesarean delivery, further recommendation, regional anesthesia is preferred. So we have talked about it because of the risk of, less risk of post-operative sedation. It is better to do in regional anesthesia. Prevention of intraoperative hypothermia is very important. It is a strong recommendation. Then it can be achieved by various means, which we have already talked about. A surgical technique, in these ERAS society recommendation, blunt expansion of the transverse uterine hysterotomy in the cephalocaudal direction is weak recommendation, but still they say there is a moderate level of evidence. Closure of hysterotomy in 2 layers, although all the studies have said it does not make a difference, but then we to be careful, and women who plan to have more cesareans, maybe if a woman is having ligation along with it, you may go for single layer, but we all advise doing layer closure in 2 layers, uterine closure. Then peritoneum does not need to be closed because closure may be associated with more of the post-operative pain. Then reapproximation of subcutaneous tissue if it is more than 2 centimeters. Subcuticular sutures are preferred over the staplers, and perioperative and intraoperative euvolumia should be maintained. Now this is also one very interesting parameter. From my PG days, I remember whenever we were taking patient for cesarean under spinal anesthesia, they were giving pre-operative fluid to the patients. So now they say that if you give more fluids to the patient, so it can have deleterious effects. So you give more of vasopressors rather than giving these fluids to the patient. So this is also one very interesting thing which has come up nowadays. Then delayed cord clamping. So it is, as Dr. Rajurkar was saying, that we should not forget about the baby. So these recommendations, they say that for term baby, delayed cord clamping after 1 minute. And it is very important that in 1 minute, you keep the baby on the mother's abdomen or over the legs. Or if the assistant is holding, the baby should be held at the level of the placenta, not above the level of the placenta. Then if it is a preterm delivery, then also 30 seconds delayed cord clamping is recommended. Baby's temperature should be monitored and maintained between 36.5 and 37.5. This is very important to avoid, hypothermia in the baby and its associated risk. Routine suctioning of the airway is not recommended. And in our PG days, we used to do gastric aspiration for all the babies who had meconium staining. But it is well documented now that in meconium staining also, if the baby is active, crying, there is no role of routine gastric aspiration. Then routine neonatal supplementation with oxygen may be associated with more harm. So baby should be kept on room air as far as possible unless it is indicated. In all settings that perform cesarean delivery, it is important that neonatal resuscitation is mandatory. So it is available there and then. Thank you so much for patient hearing.
So Dr. Shashi, would you like to say something before?
Yeah, beautifully described by Dr. Rekha Bharti. She has covered everything nicely: pre-operative preparation, per-operative techniques, and post-operative. And when I was going through the literature about techniques of cesarean section, so I came through one literature by Dhalke et al. In the Journal of Obs and Gynae 2020, and they have made a checklist based on those protocols which have been mentioned by Dr. Rekha Bharti, and they recommend that there should be an evidence-based standardized approach that would benefit institutions by improving safety and efficiency. And this should benefit residents training by providing consistency and improve teaching and strengthen future trials of cesarean delivery technique. So now the time has come that we have to standardize. We should use the evidence-based technique of cesarean section. So I'm just re-emphasizing 1 or 2 points which Dr. Rekha has said. Other flap development, omit. Placental removal is spontaneous. It should be spontaneous. There is no role of intrauterine wiping. Do it only when placental membranes are seen. And for uterine repair, exteriorize the uterus. And for closer, you should single. Hello? Am I audible?
Yes.
Single closer and indwelling catheter should not be made a practice. These are few important points. And one more important thing, azithromycin. Most of the obstetrician, Dr. Rekha, they are not using azithromycin when the patient is sectioned at the time of cesarean or in rupture of membrane. So we recommend that it should be used and the chances of infection will be less. And I can follow this checklist later on. I will just share the checklist.
Thank you so much. Dr. Jyoti Bhaskar.
I think I'm just going to be taking a few seconds. This is the second time I'm hearing Dr. Rekha speak about this particular presentation. I was so impressed with the first one. But after that, I did change a lot of my practice because it's very difficult to change what you've learned over the period of years. But then to apply that evidence, it requires a lot of perseverance. It likes a lot of belief that what I'm doing is correct. And again, it's great pleasure. And I'm sure I'm going to pick up some more points this time and reapply that so that the next time I too can audit my own cesareans and be able to say, yes, I have changed. Thank you so much, Dr. Gupta.
I will just take 1 minute. I will just comment on exteriorization. I've been trained that way long back about this, and I find that the blood loss tremendously gets. If you use it in practice, and then you will realize it, that your blood loss of your patient after the placental delivery becomes markedly less. And you are absolutely in a better control. So I will advise, unless it is not possible to take it out, that's something different because of additions. But otherwise, exteriorization definitely helps.
Ma'am, now and then, Hamesha, you have told about exteriorization. Now it has been accepted and has come as an evidence-based approach.
Doctor, I've been trained by Professor P.K. Devi, and she used to say, ये कोई नहीं करता, तुम्हारे को हर दिन ऑब्जेक्शन होगी, पर जिसमें तुम्हारे पेशेंट का भला है वो तुम्हारे उसमें तुम्हारा भी भला. So we are doing it for the last almost 73. I got 20 since that time.
And then exteriorizing the uterus, rather there are more benefits.
Dr. Achla, you want to say something?
Yeah. Actually, I just wanted to say, Rekha probably didn't touch upon it, but this, when we separate the rectus I have seen, many patients injury to the inferior epigastric. So one thing is you should only separate after opening the peritoneum a bit and, separate it with the peritoneum.
Yes.
Even after that, when you are closing, must have a look, because we've had patients referred, with hemoperitoneum, and actually it was just bleeding from the inferior epigastric. I think that should be taken care.
Yes. One thing I will like what Madam said, exteriorization has got actually 3 advantages. You can see posterior everything on the thing. If the patient is having atony, you can give additional massage. And thirdly, that it has got you can really see the everything on the thing, and you are in better control. So exteriorization is quite okay. And what we say, sometimes uterus is so big that we are not able to do it. And a little word about this, Dr. Kishore. Yes, please.
There are more advantages of exteriorization than disadvantages.
DEXA can be seen.
One thing to Dr. Rekha, what you say now, that it is a scalpel or the electrocautery. So a little bit, because every thermal injury causes some unseen damage to surrounding tissue. Are little concerned about this evidence and a cephalocaudal, because I'm really afraid when you go cephalocaudal extension, it will become a low vertical incision, which we usually don't like, and maybe some advantage of lower segment get lost. So 2 things I was really worried about it, that cephalocaudal and scalpel is fine, I think, to all of us.
No, ma'am. No problem. No problem with cephalocaudal.
Ma'am, regarding arterial and scalpel, the evidence proves that there is both can be used.
So, Dr. Energy source have become very safe now.
Yes.
Very, very safe.
आपके LVH में सारे यही तो करते हैं, मतलब we are using that only. We are not using sutures. अच्छा, I just want to ask, madam, all of you, bladder flap, आपने सबने give up कर दिए? I have not given up. All of you have given up?
I have not given up.
It should be given up. It should be given up.
Have you given up or not? In DDU? I have not given up.
No, sir, we should actually, when you give incision on the bladder flap, it just retracts if you wait, because
I am not saying, I am saying it is all right.
I learned this technique from Dr. Sain. He was in Sadhna hospital, and after that, for primary cesarean, I have never.
Yes, so we should qualify that only for a primary. You should, but for others, previous cesarean hai kuch bhi ho, you should make a flap.
In fact, sir, when we put Doyle's instrument after extracting the bladder,
because PGs are also listening, so therefore we should tell them ki primary mein kariye, but not in all.
Thank you.
Madam, question is there in the key. Can ICU, if ICU is not there, can cesarean be done? Yes, it can be done, provided you are taking a low risk. If you're taking is a high risk, then you should definitely do in a higher place.
I guess there are no more questions apart from that. Closing remarks from Dr. Achla.
I think both the presentations were very good, and I really liked the way Dr. Sadhna presented with cases. When you talk theory, it is not so interesting because we all know the complication, but when it comes to telling it with cases, then you can relate to it, and learn better.
Appreciate it.
It's a very nice presentation. And Rekha, of course, as usual, always is very good, and her talk was also very good, though of course what evidence say is all the evidences come from not from India but from abroad, so we can't follow all the evidence which is there. We have to visualize and do in our own practice, like Dr. Kishore said, that bladder flap only when it is a clean cut cesarean and nothing else is there. So but yes, we must know what the evidence says and generate our own, I think.
Ma'am, even the evidence says whether you give bladder flap or you do not make bladder flap, after 6 to 8 weeks, the voiding problems and all would be same in both groups. So even if you feel that we have to make it, because here, as sir said, even residents are doing. So it is not being done only by very expert people who have been in this field for very long. So that is why, but they also say that short-term complications will be there, but long-term complications are not different whether you are making flap or you are not making flap. So as far as recommendation, it is still a weak recommendation. Like if we give it, rather it was whether you make or you do not make, whether you exteriorize or you do not exteriorize, it will not, because initially, we used to be told by anesthetists that don't take out uterus, patient will have vomiting. So it is evidence-based that there is no increased risk of nausea, vomiting, and even post-operative complications are not increased if you are exteriorizing the uterus. So basically, these evidence are reinforcing what we are doing. Those who are opening with scalpel, those who are using electrocautery, both can be used. So it is only one different recommendation which I still have to see by doing it, as Dr. Rajurkar also said, opening it craniocaudally. But we have, like I did in one case, because in our institute, mostly residents are doing cesareans, but I did in one case, it didn't extend. But then we have to do it more to say that start doing this rather than, just recommending it.
Can I take a minute?
Yes, ma'am. आपके comment चाहिए.
After cesarean section, if the cesarean has been done under spinal anesthesia and you've seen absolutely it was bloodless, one prick and that you were inside, sometimes there can be hematoma at that level. Now, so you always must write down on your notes that the patient must move the legs in 3 hours time. So, and after that, please make it a note also, जब patient के movement हो जाएंगे, मुझको phone जरूर कर देना. Why? Because it is said, you operate in the evening and you come in the morning, it is more than 12 hours. The hematoma has to be operated within 8 hours to avoid paralysis. If the paralysis has to be avoided, it has to movement, you should notice it in 4 hours time. So this has come, there have been cases which has gone on from State Council to the Medical Council of India, when you find that, these doctors, anesthetists, as well as the surgeons get involved into it. And we did not know anything about it, that this kind of an activity must be done within 8 hours. If the surgery is required, the surgery has to be effective, it has to be done within 8 hours. So please write down in your notes that the movements of the legs must be seen in 4 hours time. So anybody who's listening me should definitely see to it that the nurse should give you back a call that patient move kar raha hai, madam, legs. So this particular part must be noted, because otherwise it is too late by the time you diagnose it.
And one thing, Dr. Rekha, thank you, Dr. Sharda. It was very, very, very pertinent, because it is some of the post-operative complication, neurological, again, very, very important, which we are not doing actually. What we can say that, Dr. Rekha, but it is all that study says now about this spontaneous expulsion, active management of third stage of labor. That is like we recommend very, very strongly, and especially for cesarean now, carbetocin, because especially for elective. So any comment that it is a part of PPH prevention or something and it is not included?
Ma'am, carbetocin has not yet come in the recommendation. Like it is there, it has been, the studies are there regarding its effect. But as far as recommendations are there, we are still giving oxytocin. We have not shifted to carbetocin. Although there have been studies still going on and few people are giving it as a research project. But it is not there to change it with carbetocin in the recommendations.
I think
carbetocin for prevention of PPH is the drug is the first line of drug. A lot of work has been done in Europe, and it does not require recommendations of few hospitals that हमारे पास नहीं है और ये recommendation नहीं है. It is number one. It is a first line for prevention. First line for prevention.
Very good, very good.
It is actually not there in the hospital, like we are in the...
Madam, it is in a pipeline. Sun Pharma is supplying into the private sector and the ferring is supplied to the government sector. The government has agreed they will supply it for 89 rupees, this carbetocin. It is in the process, and I'm sure in a month's time you will get it.
That will be a great,
yeah, especially
and these people are working on the tablets, which can be
reducing the IV flow, especially in the high-risk patients.
So that particular thing also will be there in 22 end.
And especially in the high-risk patient like severe anemia or hypertension and heart disease, where we want to decrease the fluid intake and also not have PPH, then we keep the oxytocin in drip. That can be avoided with carbetocin,
Actually, ma'am, for active management, only 10 units IM is recommended. Drip is only.
No. But Rekha, when
yeah.
you're doing cesarean
Yes.
and high-risk patient, we are not giving.
So
10
there
units
in high risk, when you are giving post-operatively, it should be given.
For that,
It is recommended that the carbetocin which you give takes 1 minute. And you,
Yes,
during this particular time, don't handle it. Just watch how the placenta separates.
yes.
It's a treat to you.
Yes,
Because the
yes.
physicians don't allow you to touch the baby because 1 minute has not passed. And the carbetocin is working, takes 1 minute. And उस टाइम बस आप कुछ मत करो और खाली प्लेसेंटा की छतरी को निकलते देखो. बहुत बढ़िया लगता है.
बस बहुत
Madam, can I just share one practical thing which I used to do? I actually जब cesarean में high जो head high होता है ना, head high. When the head is high, then जब incision देने के बाद, uterine incision देने के बाद, I used to ask the anesthetist to put 5 units oxytocin. And उसके बाद देखो हेड नीचे आता है, प्लेसेंटा प्लेसेंटा सब बहुत ही बढ़िया चला.
डॉक्टर राजूकर, आप कुछ कह रहे हो कि रेजिडेंट्स बैठे ऐसी डेंजरस.
No, I'm not. I don't know. You can try and see.
डॉक्टर अंजला बताएंगी. डॉक्टर अंजला ने मुझे उस दिन बताया था, उसका नाम बदल गया. उन्होंने कहा जब यूट्रस बिल्कुल रिट्रैक्टेड हो, that she gives some uterine relaxant and you can find, the wonderful, the baby comes out. Dr. Anjala, if she's there, she will share. Is Dr. Anjala there?
नहीं मैम, she had to log out because I think number of people who was.
But madam, maximum Dr. Achla Batra and Dr. Rekha has got the Sadhna Jain Hospital is the institution जिसमें सबसे ज़्यादा experience होता है. So we need not depend on बाहर के experience and we can always, depend on you people, madam. मतलब बहुत ही ज़्यादा इसमें cases होते हैं. Cesareans पता नहीं कितने cases cesareans per day होते हैं. I think we can learn maximum from them instead of just following the recommendations.
Ma'am, should I go on with a vote of thanks? I think.
Meenakshi, can I just drop in here? Meenakshi, this is Dr. Geeta. Can I just say a few words?
Sure, Dr. Geeta.
Okay, as Dr. Sharda Jain has mentioned, and I had talked in my last lecture about carbetocin, I just talked theoretically about 3 months back, and then we got it in Gangaram. And believe you me, what Dr. Sharda Jain has said to the T.
Absolutely.
I have used carbetocin. If you can just have patient with dengue, 2,000 platelet. She came in dengue shock with previous 2 cesarean in labor with 1,000 platelet and carbetocin saved me.
Oh, that's amazing.
Patient lives.
I think
I use this platform to say कि carbetin AMTSL के लिए सब use करें, please.
Absolutely.
Absolutely.
Dr. Sadhna, last word from you.
I will say thanks for wonderful input and all the thanks, hearty thanks to Dr. Sharda Jain, AOGD, everybody who was with us today. And cesarean section is what is our bread and butter day in and day out, and we should do everything evidence-based. But what Dr. Kishore says and everybody says, we have to create our own evidence. Because this is thing, because carbetocin is not available in high economy, that is US and Japan. And that's why their insurance system and many things are there, and our country is much more progressive, and we are catering with much more load of patient. And when we believe in something like Dr. Sharda Jain says, Dr. Geeta says, I have been using since 3 months, and what we say, next second it is a placenta which is separating and no post-operative oxytocin. So we are the Dr. Achla Batra Sadhna Jain Hospital. We always are, jab Sadhna Jain team is so like in our saving mothers when residents were.
Dr. Sadhna, ये तो हो ही जाएगा. आप अपनी request कर लो दोबारा इनको. Then we close.
Thank you. And earnest request from a earnest candidature. What I can say that I have served with dedication, excellence, and keeping always a common woman, a common obstetrician, keeping in frame and always working what should work best in our country. And we have to be very proud obstetrician, clinician, and world is looking for us. And it is the time that our profession is not to the few cities or few classes or few very, very expert, but it is the time that we join hand, we give confidence to every obstetrician and gynecologist, and we handhold for every obstetrician, every gynecologist who is working pan India. So this is my, like what we say, I have always kept this principle throughout my life. And the Delhi Society, I think many people know it, and we have a very, very close bondage. Like Dr. Kapralani was our my president. So we had a long bondage, and the Delhi, when with my candidature, North will have that place and strength much more evident, much more prominent, and always I've been impressed. Very, very academic, high quality academic excellence in Delhi, and we think and we look forward that our Delhi AOG expertise and all the eminent teacher, mentor, clinician will take a very strong part in the future Foxy with my candidature. So my candidature is your candidature, my voice is your voice, and I have come to this this moment when I fight for presidential candidature with a very hard struggle. It was not easy, and it was very many resistance, many things, but it is the work, and it is your belief in myself and belief in people and belief in God, which took me, always carried me. And again, I seek very, very earnestly, full-hearted vote and support from the Delhi Society, and all blessing for all the teachers, mentors from the Delhi, and we can say from all over the country also.
Thank you, Dr. Sadhna. Thank you so much to our honored guests who were here, Dr. Sharda Jain and Dr. Achla Batra, for all the encouraging words. Our wonderful speakers, it was a delight to have an academic feast which was so practical. Dr. Sadhna and Dr. Rekha. Thank you to all the chairpersons for giving in their valuable inputs. Thank you to Dr. Uma for being my co-host. And thank you to all the listeners, because we had a full house till the very end. Thank you so much and have a pleasant evening. Thank you. Thank you to Malvika from Life Care for giving us the back-end support.
Secondly, Dr. Saab, आपको तो इस presentation के बाद बुके मिले और हमारे लोग को थप्पड़ मिलेंगे क्योंकि आधे लोग join ही नहीं कर पाए. It was so full. It was over successful.
We will be sharing the recording on all our platforms, on all the 9 DGF forums. We will be sharing the recording, and I will share it with Dr. Achla also so that it can be posted on our AOGG pages also.